Thank you, everybody. Let's now start the presentation with the amazing Professor John Ireland. I'm just going to share my screen now to his presentation. Thank you. There we go.
Okay, right. So if you want to move on from that first slide, please. Okay.
Yeah.
So this is the data that I was talking about, and the numbers there, as you can see, are pretty impressive. You see there on the left-hand side of that screen, that's just for hip replacements, and the current rate of complications and revisions is around about 10% after 20 years. We move on, please. Next one, Michelle. Okay. So the other interesting thing is that we've seen a progressive increase in patient satisfaction from the surgery, but it has not achieved 100%, and some of that's down to obviously deficiencies in the technology, but some of it is personality based as well, and we haven't developed really good tools to select, I think, the optimal person to have patients, and nor do we, I guess, from a kind of moral point of view, have that ability to deny people technology. So the rate of satisfaction for conventional hip replacement runs around about the 90% mark. We move on to the next slide there, please, Michelle. Okay. Some of the other interesting things which have come out of it, and this is intuitively we know this, but there is now really solid data about the impact of obesity on the end results, and the difference between underweight, normal weight, and morbidly obese patients is about 6 times risk of infection. We'd always sort of knew that there was a greater incidence, but it's now being quantified, and it's quite striking. And certainly it's a conversation which surgeons need to have more frequently with an increasingly obese population that we're dealing with. Next slide, please. Another area which was obviously very, very topical 5 years ago or 10 years ago was the whole argument around the use of metal-on-metal bearings, and you're probably all aware of DePuy and the ASR prosthesis and how that seriously had some serious defects and resulted in a very high failure rate. So on the left, you'll see the results of metal-on-metal bearings that were quite commonly used and aren't that commonly used now, although some surgeons still make an argument for using them, particularly in younger males. The very poor results in metal-on-metal, obviously a reflection of the ASR in particular, but also the fact that doing resurfacings, which is basically putting a cap on the normal femoral head and replacing the socket or the acetabulum, there was a very high incidence of fractures, particularly in women who had resurfacing. So that became evident after a few years. So that's that slide on your right, where you can see the disparate results for males and females using those resurfacing procedures. Next one, please. So moving on to knee replacements, ratio of knees to hips is in the vicinity of 3 to 1. The number of people who are getting to that point in their their lives where they've played an enormous amount of sport, been very active all their life, and are finding that their joints just aren't coping anymore. I'm one of them, having knee replacements, and I think that number is going to just keep on climbing and climbing and climbing. So the satisfaction with total knee replacements is not quite as good as hip replacements, but still not too bad. You know, some of this I think would be improved by patient selection, and obviously there are some improvements to come, I guess, with the technology we're using. The other things that I think that are helping both with satisfaction is the use of technology, and we're using computers, we're using robots, and we're achieving kind of more refined alignments and spatial arrangements with both hip replacement and knee replacement, and all that has made a big difference. Also, the use of pain techniques post-operatively and improved rehab techniques have meant that people are far more ambulant and progress far more quickly than they did 10, 15 years ago. And using some of the drugs that we do now, the incidence of people needing transfusions after surgery has dropped dramatically. 15 years ago, probably for knee replacements, 10% of people would need a transfusion, and for hip replacements, 15%. Now we're talking about single digits. I can't remember the last time for an isolated knee replacement we did a transfusion. And hip replacements are very low. Bilateral joint replacements, which we do a lot more of now, obviously have a slightly higher incidence. Next slide, please. So shoulder replacements, which I briefly mentioned, has become more popular basically through the aging population, the fact that the technology is available, and people who have suffered with very painful joints for long periods of time, particularly if they've had rotator cuff tendon tears over long periods of time, and now getting fairly good reproducible results from having shoulder replacements. And what started off as a trend, mainly in younger patients doing total shoulder replacements, which basically was replacing like surface with like surface. So, you know, where the ball part of the humerus was removed, a ball section was replaced there, and the socket part with a socket. But the reverse shoulder is the reverse of that. And the benefit of that is that it doesn't rely upon the rotator cuff muscles, which are the weak link in trying to maintain a mobile and pain-free shoulder in older patients. So it's become the go-to procedure for anybody older, and particularly people who have got very poor rotator cuffs in association with their arthritis. And you can see there on the right that the revision rate were largely for rotator cuff deficiencies, and that is a reflection of the early trend of doing total shoulder replacements. But look, nothing's perfect. Shoulder replacements have their inherent risks as well. We move on the next slide, please. And what we're seeing with shoulder replacement satisfaction rates is that they are also fairly high, and they're improving all the time. So the functionality of reverse shoulder replacements is improving with our improved understanding of it, with improved therapy techniques. So we're finding that more and more patients now are coming. So the number of people having shoulder replacements is increasing exponentially. Next slide, please. So complications. Now here, we know that there are complications which are a recognizable risk. Then there are those that can occur because of poor planning or poor technique. And we have to make a distinction between the surgical complications, the ones that are associated with the actual procedure itself, and general medical complications. So people who are developing problems with blood clots, pulmonary emboli, having myocardial infarcts, or gastro disorders when I guess subjected to these operations. So the complications, not all complications are registered with the registry. The ones that are the ones that are associated with the revisions. So patients may have a minor skin infection and it not result in them having a replacement or revision. And also if they've had a pulmonary embolus or a DVT or something like that, that's not recorded on the registry either. So you can see there on the left, that's the most common list of reasons for revising a hip replacement, on the right for a knee replacement. So we just move on, and what I have here is just an overview of the general or the most consistent risk, which is the one which is not diminishing substantially, and that's infection. That still runs about 1%, and that risk, as you've seen from the registry data about obesity, is also linked to comorbidities. So the risk increases with the age of patient, with their increasing morbidities and their increasing weight. We just move on next to a few case presentations. These are cases that I've been asked to comment on, and they may be of interest to you. And these sort of represent, I guess, some of the common reasons for litigation. So we go to the next slide, please, Michelle. This is a patient who is 58 years of age, a very active gentleman. He worked in a bank, had an accounting background. He underwent a left total hip replacement in 2010. And he ended up with a significant leg length discrepancy of 22 millimeters. The patient noted it post-operatively, and the physio noted it post-operatively. The surgeon apparently did see the patient, but didn't respond to any of those issues. Patient was discharged, and then at the 6-week mark, the patient was noted by the surgeon to have a leg length discrepancy. Unfortunately, he kind of missed the boat. It becomes a far more difficult situation to deal with if the prosthesis had an opportunity to ingrow, and it becomes a much more difficult thing to deal with. Some of the symptoms that were associated with this problem for the patient were he had back pain, he had difficulty with his footwear, he was unable to dance, run, walk long distances or work in the garden. So it was quite debilitating for him. And it was, I think, in retrospect, if it had been picked up early enough, it could have been remedied quite easily. So this is just a X-ray of the initial hip. You can see that the hip replacement has been placed a bit too high, and if you look at the other X-rays on the other side, they're the scans measuring the leg length discrepancy, and 22 millimeters is a substantial difference. These days, with the technology that we have, we should theoretically be able to achieve a few millimeters of difference. If you look at the literature back in the 80s, there was a paper that was done by a group of Australians, actually, and 80% of hip replacements were less than 2 centimeters. So back then, in the early days of joint replacement, big discrepancies were not uncommon. And progressively, as techniques have refined, and also the adjunct technology that we have available, has made a big difference. So now with computer navigation, for instance, and doing preoperative templating, and that's can be done with specialized X-rays or CT scans. We can plan pretty carefully what we need to use to do it, and intraoperatively in real time orientate things and get as close as possible to that with length and offset and the spatial arrangement of the hip. And so even in 2010, you know, there was 22 millimeters was considered far more than would be acceptable. And you know, I would have thought that even these days now, anything more than about 10 millimeters is a cause for concern. The other thing, which nothing's ever as simple as it seems, but we have patients who present with lots of different types of pathology, and if they've had a significant leg length discrepancy, i.e. the hip's been very short because it's eroded down, and it's been like that for many, many years, or they've had a dislocated hip, and you put them back to what you consider to be equal lengths, patients may still not be satisfied with that because they don't feel comfortable with it when they're walking, and quite often it can result in some adaptive problems with their spine because the spine's adapted to that leg length discrepancy over many years, and all of a sudden we've gone back to a situation where the leg lengths are equal again. So there are conversations that you also need to have with the patients before you have the surgery, just to warn them that even if you get it perfectly right, they still may have symptoms. It's probably not a conversation as orthopedic surgeons we have often enough. Next slide, please. Nerve injuries in total arthroplasty. This is fortunately not something you see too often, but the incidence of nerve injuries varies depending on studies, the groups that you're dealing with, from 0.1 to 3.7%. Most of them occur around the hip, but some do occur around the knee and the shoulder, but they are very rare. Around the hip, I guess in order of priority is sciatic nerve, and then around the front of the hip, femoral and obturator nerve, superior gluteal and lateral femoral cutaneous nerve. And the latter ones have become more of an issue as we've done more and more anterior approaches to the hip. As you may or may not be aware, with the whole thrust of doing less invasive and potentially more stable hip replacements, there's been a trend towards doing a anterior approach to the hip. So that has its own kind of difficulties, both from exposure point of view and potential risks to nerves. If we start looking at revision surgery, then the risks of nerve injuries become a lot higher again. And the damage to the nerve can occur for many different reasons: compression, traction, ischemia in the nerve, and it's very rare to actually transect a nerve. I certainly haven't seen a transected sciatic nerve or femoral nerve in my career as a direct result of the surgery. I'm sure it happens, or it has happened, but I haven't seen it. More often than not, there's been an issue with either the traction, positioning, some bruising the nerve from improper retractor placements, or just through manipulation if the hip dislocates. Very uncommonly, if there's a large hematoma there, that can cause pressure on the nerve and result in a potential nerve problem. There is also a higher risk if you've got spinal disease, because that will often lead to some tethering of the nerves in the foramina. And our whole nervous structure is an elastic organ. So it has freedom of movement from the base of our brain all the way through to our toes. So if it is impinged anywhere, it reduces the ability of it to withstand any stretching movements. And one of the other things that we have discovered over time is obviously that limit to the amount of lengthening that you can get away with. And 4 centimetres has been shown to be the absolute minimum that the body will tolerate. And we obviously don't try and go anywhere near 4 centimetres lengthening any hips. And that's an area that sometimes, particularly with people who have had congenital dislocation of the hips and they've been short for a long, long time, can be difficult to get the entire amount back without compromising and leaving the leg a bit shorter. It's a higher incidence in females, and as I said, talking about dysplasia, that includes things like congenital dislocation of the hip. Posterior approaches obviously have a higher risk of affecting the sciatic nerve. And if we go to the next stage, next slide, then you can potentially see why, because the nerve is very close to the hip joint, and it's more subject to local trauma and damage, and obviously manipulation around the hip has a more direct impact. A lot of times we don't, patients who have a sciatic nerve injury, we don't always have any obvious cause for the onset of symptoms. I mean, sometimes you can quite clearly identify what the cause is, particularly if you over lengthen them or something like that. But sometimes you just can't. Move on, next slide, please. So these are situations on the top left there. That's the appearance of somebody who's had a dislocated hip when they were younger. They've developed secondary arthritis, and you can see there's a very big difference in their leg lengths, and trying to bring that back down to place it in the appropriate place puts a lot of tension on the nerves in that area. On the right-hand side, there is some x-rays of a patient that I've provided opinion on recently. This lady had quite severe osteoarthritis, and it's a condition we call protrusio, where the ball erodes into the socket, so it effectively closes down the gap between the trochanter and the actual acetabulum itself. And it's quite a difficult situation to replace in that situation, because as you can imagine, looking at the diagram in between, if that difference between the edge of the socket and the rest of the femur is reduced, brings you a lot closer to the sciatic nerve. Anyway, the surgeon's done a good job in replacing the hip, but unfortunately the patient ended up with some damage to the sciatic nerve and a sciatic nerve palsy. And there is no difference in leg length there. He's done a good job of orientating it. So it's an unfortunate complication. We go to the next slide, please. Now, we can always come back to questions about these at the end of the presentation, but I will talk to you about risks of dislocation and a condition which is being talked about more and more amongst orthopaedic surgeons, and it's what's called a spinopelvic disorder. And all that means is that the problems that occur with hips, and particularly the potential for dislocation, can quite often be complicated by any spinal disorder or any previous spinal surgery. So if the spine is very stiff, it has implications for the relative orientation of the socket and then that has that a potential increased risk of dislocation. And I'll come to some diagrams in the next slide. But this one here is a patient, and this is a bit of a shaggy dog story. Kept me interested for quite some time. This patient had severe OA of both hips, and 68-year-old male, had a previous spinal fusion over 3 levels and a very stiff spine. It was done in 2014. In 2018, had a right total hip replacement done, and the original hip was done with computer navigation, with assistance of computer navigation, and by surgeon A. Not long after, there was a posterior dislocation, which was reduced, and then another dislocation, which was reduced by another surgeon. And then not long after, a further dislocation, which was addressed by the original surgeon. And then it was decided, well, it's obviously no good. We better go and revise it. So surgeon A plus surgeon C went and did a revision. Unfortunately, that didn't solve the problem. The patient dislocated again. And then it was referred off to some hotshot in the city. And this is, I think, south of the border. And another revision procedure was carried out by surgeon D. He identified that perhaps there was a lack of anti-version in the socket, and I'll explain that in the next couple of slides as well. And he replaced the hip, but in the process, he ended up with the hip being 1 centimetre too short. And that created significant stability issues because the muscles were defunctioned. Anyway, the patient continued to complain of pain, falls, weakness, and not surprisingly was depressed, and had a dislocation again some months later. And the surgeon D went and revised it again. So we go to the next slide. So this is the revision that occurred on the left there, and you can see its hips reduced, but it's shorter. And then that's the end result of the patient's had what's called a constraint line. So it's actually goes over the head and is locked by this retaining ring. So it's extremely difficult to dislocate. So clearly the issues that were affecting the orientation, the relative orientation of the socket, was such that the patient, if they were trying to get out of a chair or something like that, was putting a normal strain on it. We go to the next slide. So on the right there, you can see that in the normal spine and the normal orientation of the hip, we have the ability for the spine to flex forward to take the pressure off the hip when we're getting up from a seated position. Whereas if we've got a stiff spine, then the whole of the body pivots on the hip replacement. And when that happens, if you're going beyond that 90 degrees, then there is potential for the components to impinge on each other and dislocate. And this is a sort of situation that was occurring in that previous gentleman. So this spinopelvic disorder has something been talked about widely for the last 10 years, major topic of meeting for about 5 years. And we know that in the presence of significant spinal fusion, the dislocation rates are much higher. And there's a paper there from Sultan where the dislocation rate at 1 year was 3% and at 2 years, 7.5%. And it's really an area now which surgeons need to focus on. And there is technology out there which helps identify these patients. There are various computerized algorithms which give you an idea of what the impact of a spinal fusion is going to be on a hip replacement. So there are areas that need to be looked at, and unfortunately, sometimes they're not addressed. We move to the next slide, please, Michelle. So just still sticking with hips and backs, there are certainly situations where patients are very difficult to diagnose. This is not really one of them, but this is a lady who is 58. She's a secretary. She presented with pain in the left groin through to the buttock. But interestingly, she had pain when sitting and she needed a standing desk to work at. So they're kind of all red flags for somebody having a back problem rather than a hip problem. But anyway, she saw surgeon A, who felt that her problems were coming from around her butt and over the ischial tuberosity, and tried an injection in that area, got some temporary relief and suggested this need to be explored. Not surprisingly, the patient didn't think that was a great idea and decided to get a second opinion. Saw the surgeon B, who suggested that she needed a hip replacement. So that was proceeded to in November 2017. She continued to complain of pain and she went back to surgeon A, who felt that her problem was due to impingement. Now, if you look at those little images on the right there, the top one obviously is in a normal person with a normal back, generally the orientation of the socket that we put into the acetabulum. If, as is in the lower image, you get part of the socket protruding beyond the anterior margin, there is a tendon which passes over the top of that. It's called the psoas tendon. And then if that starts rubbing against that area, it will cause symptoms. So that's soft tissue impingement we're talking about around the hip. Anyway, so he released that. Patient was no better. So it went back in 2019 and had a revision of the cup. I have to say that the original indications for the hip replacement pretty tenuous anyway, but needless to say, she was no better after that surgery. And last records of her chiropractor show that the pattern of pain had not changed from prior to total hip replacement to her last consultation in 2020. So it's sometimes very difficult. You can chase the rabbit down the rabbit hole, and but certainly there are a lot of red flags there that probably would have mitigated against doing any procedure without first getting the patient seen by a spinal specialist first. This is a mistake a lot of surgeons make, and it causes a whole lot of trouble for them, not least their patients. So the fact that if they had a assessment of spine first, doesn't always help, but it certainly would have been in their interest to exclude any major pathology in the back. We have the next slide, please. Just to recap on impingement, which we talked about briefly, there's soft tissue impingement around the hip, and then there's mechanical impingement in the hip joint. So if you're ever reading this in a document, you'll have a bit of an idea of it. So the impingement can either happen between bony prominences, and that's more likely to happen if the amount of offset or the orientation of the components means that the bones can abut each other. More often, the impingement is due to the components abutting each other. And that will be more of an issue if they're not orientated accurately for that particular patient. All right, so we move on, next slide. This is infection and pulmonary embolus, not an unusual scenario. It's a 50-year-old obese farmer who had a left total knee replacement back in 2015. sometimes you get stories which are a little bit confusing and sometimes give you a bit of a false impression of where things are going. He was chopping wood and it felt a pop in the knee, and that was in 2016. Around about that time, he also had some dental work. And when he was initially assessed, he had an X-ray and somebody did check his temperature and it was okay. So, but over the next 12 months, he had fevers. He had at various times elevated CRP, and CRP is a method of measuring potential infection. Also is it can be sensitive, but it's not very specific. So it can also be elevated for many other conditions. But certainly, if you've got a high if you have a real sense that there is a risk of infection, CRPs are obviously can be quite helpful. The patient was put on for flucloxacillin, an antibiotic, for a period of time. It eventually became clear that it wasn't resolving the problem. In 2017, had an arthroscopy which grew and aspirated some fluid, which grew streptococcus. As a result, they removed the knee replacement. He had a fairly variable course over the coming months with difficulty controlling the infection, and eventually they did, and they discharged him home. But not long after he got home, he experienced severe chest pain and had a cardiac arrest and died. And next slide, please. It was found that he had a pulmonary embolus. So needless to say, he had a very stormy course. Family weren't happy. It was a relatively young man, young family, and it was a very unfortunate outcome. One of the areas which has been a bit contentious over the last decade or so is what level of anticoagulant therapy is appropriate, and still have an argument, particularly by orthopaedic surgeons, about the use of such things as aspirin rather than using much stronger chemoprophylaxis. And the argument from orthopaedic surgeons is that, well, you know, all those really strong anticoagulants just lead to more bleeding, bruising, and increase the risk of infection, which is true. But aspirin, although can be effective for low risk cases, is not as effective for high risk cases. And there are a lot of these algorithms which have been put together mostly by hematologists, admittedly, but they have become the go-to for most people dealing with potential venous thromboembolism and stratifying risk and what is appropriate for that risk category. And most hip and knee replacements fall into the high risk group. And therefore they need something stronger than aspirin, particularly if there's other issues, such as in this case, obesity, if there's been a past history of cancer, diabetes, anything that, increasing number of comorbidities that may increase that relative risk. So that's an area which has occasionally caught out orthopaedic surgeons. They've just put somebody who really should be on something a lot stronger just on aspirin, which is probably not adequate. And certainly if a hematologist provides an opinion on those things, they're generally quite scathing. It's one of the beauties of any specialty. There's always another specialty who wants to dump on you when it becomes appropriate. Can we have the next slide, please? Fatal pulmonary embolus. Well, this is just getting back to what we were covering there. It's still very low risk of it occurring, and the risk of postoperative fatal pulmonary embolus is still being quantified as 0.02% using a lot of the Medicare data in the US. So it's certainly very low, and there's a lot of, as I say, there's a lot of contentious arguments about which is the most appropriate to use. The bottom one there is a study which has been done by anaesthetists, so they're pretty unbiased, and they were just looking at potential complications, medical complications in patients. And this is out of 10,000 hips, 10,000 hips and knees, and they found that there was an overall rate of myocardial infection of 2.2%. Sorry, of 2.2% was total, but myocardial infection was 0.4%, pulmonary embolus 0.7%, deep venous thrombosis 1.5%, and death 0.5%. Now, I'd stress that's almost 20 years old, that study, and things have changed a bit. We are now doing more day surgery or limited stay surgery. So patients are going out home after their hip or knee replacement after 1, 2, or 3 days. And so they're not getting tested. So there's certainly, if you want to test people, you will very often find small clots in superficial veins or even deeper veins in a lot of patients if you start doing tests a week after surgery or 2 weeks after surgery. But they're not clinically relevant in most cases. So there is a bit of difficulty interpreting the literature in this area. Next slide, please. So vascular injuries. This is another interesting case. As a 75-year-old gentleman who lived in regional Queensland. He had a history of vascular disease and had a aneurysm, popliteal tendon, which had been grafted by a vascular surgeon. He also had severe OA of the knee. He saw an orthopaedic surgeon. You've sent him for review by the vascular surgeon. The vascular surgeon said, sure, but don't use tourniquet. There was no clear indication of exactly what anticoagulants the patient or the surgeon was supposed to use. But the patient was only on aspirin, and they ceased that just before surgery. This was done in a regional hospital in 2019. And there was nothing in the notes that referenced whether they did or they didn't use the tourniquet. They restarted the aspirin afterwards, after the patient went to the ward. Following day, the patient complained of altered sensation and some pain, and that intermittent pain got progressively worse. The patient eventually was taken back to them, and this is one of the problems with dealing with patients in country settings. Although they had a vascular surgeon who visited this particular town, they didn't actually have a vascular service, so the patient had to go back to the regional centre to see the vascular surgeons again and had an angiogram, and it showed that the graft had blocked. So there was a period there where and I think this tends to happen quite a bit in country towns, the surgeon takes a lot more responsibility across disciplines. And ideally, I think he missed the opportunity to get the patient reviewed by the vascular surgeon. Now, I don't know the full background of this, whether or not the vascular surgeon was only come once a week or once a fortnight or whatever it was. But probably when he started to have problems, it would have been in his interest to send the patient directly to that regional centre to be sure that the graft hadn't blocked. So they kind of missed the boat. And as a result, the patient's got persistent pain and disability. And it's not a good outcome. We have the next slide, please. So, Michelle, we're sort of getting out towards the hour. I can keep on going for ages. There are probably some questions there, and
Well, we've got 2 more slides to go. If you wanted to just skip through those, then we can see if there's any questions. Is that okay with you?
yeah, okay, I'll do. Okay, so this is a 35-year-old with a fairly complex history. He had a history of brain cyst, anxiety, depression. He'd had a previous pulmonary embolus. He was an ex-alcoholic, an ex-smoker. He presented with pain in the hip in 2013. Surgeons did everything they could to avoid doing surgery on him for 5 years, but he eventually had a hip replacement. And he had persistent pain after the surgery. And they kept on looking for causes for the pain, and he had a neurological assessment where they thought that they had a ruptured disc at 2-3, which was causing the symptoms. And it took them quite some time before they eventually found that the prosthesis was loose. The benefit of hindsight, there was another surgeon became involved, did some x-rays, did some scans, and said, it's loose. So there was a very protracted period, which was a bit confused by, I think, suspect partly him, and then partly this, potential disc problem. So the patient went through a lot of symptoms over a long period of time. Another area which is we see a lot of, as far as complications concerned, people turning up with very stiff knees and painful knees. We don't always find a cause for it, but we certainly need to be sure that they don't have an infection, they don't have any obvious loosening of the components, and things such as instability or malalignment. And stiffness is particularly associated with mechanical malalignment in the knee and low-grade infections. And they can be very difficult to detect. There are bugs that we're dealing with now, which we didn't have to deal with 20 years ago, because 20 years ago, they were all staph, and they had a florid presentation with high fevers, a lot of pain, a lot of swelling. Whereas some of the bugs that are getting into joint replacements now are very low grade, very insidious. They won't necessarily have a fever. The pain could be variable. The amount of swelling in the knee could be very variable. And it can take quite some time before the penny drops and people start hunting for an infection. Anyway, I'll stop there. So if there are any questions, I'm more than happy to answer them.
Doctor, we have a question here from Jill. What is the cause of infection in obese patients?
It's a very good question, Jill. Obesity is a metabolic disease. So it alters the function in all the organs and at the cellular level, and it decreases the immunity in the body. I think I'd probably need a good endocrinologist to explain it all in detail to you. But if you just think of obese patients, very similar to somebody who's got diabetes, because fundamentally they've transferred their weight, their fat cells from normal white cells to yellow cells, and the type of metabolism is totally different, and this is why we have so many difficulties with people who have bariatric surgery and expect them to be normal. They will never be normal, and they almost invariably end up being fat again, because there's just that capacity in the body, and also for various other reasons they will generally eat their way around a blockage to get to that state again.
We have another question here, sir. Thank you for that answer. Is it safe for a person to have a left hip replacement 8 weeks after having had a right total knee? Yeah. There's no indication. If the patient's made a good recovery from their knee replacement, then having a hip replacement's not so much of an issue.
very uncommonly, we do bilateral hip replacements, which is a bit more challenging. But as far as a knee replacement on the opposite side, it's not a problem.
I have a question from someone who wasn't able to attend, and they were saying that, beg your pardon, they had a first knee replacement about 10 years ago, and the scar is straight down the front of their knee. Then they had their other knee done, and the scar is around the side, or it's not straight, she says. And they're saying, is there a reason why that's done differently now?
Yes, I'll just show you my knee, Michelle, because I've had that exact issue there. Can I get it up there? That's my knee. It goes around the side here, okay?
Yeah, okay.
So, the rationale for that is that there's been some studies show that as far as sensitivity across the front of the knee is concerned, it is far less, because the main skin nerves actually come in from the inner aspect of the thigh. So traditionally, when we've made the incision down the middle, there is an area, a patch of numbness on the outside part of the knee. But more importantly, if those nerves, as they're regrowing, get caught up in the scar tissue, it creates a lot more sensitivity. The scar obviously is generally quite, if it's down the middle, is right over where you kneel. So it does make it far more difficult for people to adapt to squatting and kneeling. And these days, we don't put restrictions on people who have knee replacements. So, I mean, you know, in the past, surgeons used to tell patients, oh, we don't want you squatting and kneeling, we don't want you doing this, we don't want you running, there are no real restrictions now. So we want patients to kneel, we want them to squat. And from personal experience, I can tell you that doing the incision around the lateral side does make it a lot more comfortable. Not every surgeon's doing it, and it's something that probably will happen more and more over the coming years.
Wonderful. Does anyone else have a question that they'd like to ask Associate Professor John Ireland? And pop yourself off mute if you want. Okay, I have one last question, and it's from a physiotherapist. And he asks, would you say that where people do their exercises and their physiotherapy post-joint replacement, they have a better outcome than those who do not do it and who rest?
We're talking about hips or knees, or what are we talking about?
Just says joint replacement.
Look, I am convinced that a good post-operative therapy program makes a big difference to not only the speed of recovery, but the quality of recovery. So I think it's an essential part of the whole process. We all get stuck in little silos and only worry about our own part of it. But I think, you know, the whole patient experience is very much about how they're dealt with from the time they come to see me, the nurse who gives them the education, the way they're treated in the hospital, and the therapy they get afterwards. And physiotherapists are an intrinsic part of that.
Wonderful.
A lot of arguments for doing therapy prior to the surgery as well.
Okay, that would make sense. Look, everyone, thank you very much for taking the time to join us for this seminar today. The recording and the slides will come out to you within a day or so. I'd like to again thank Associate Professor John Ireland, amazing orthopaedic surgeon. He's been associated with MAG for some time. He writes an excellent report, and his advice and opinions are highly regarded. Thank you all, and go and have a great rest of the day.
Thank you.
Stop recording.